Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Takeda.
This program is presented by Medscape Education Global.
Hello, I'm Nicola Petrosillo, head of the Service of Infection Prevention and Control at the University Hospital Campus Biomedic in Rome. Welcome to this program titled Dengue, a leading cause of travel-related fever, vaccinating travelers to endemic regions. I'm very pleased to be joined today by Thomas Jelinek, who is Medical Director of the Berlin Center for Travel and Tropical Medicine in Berlin, Germany. Welcome, Thomas.
Thank you, Nicola. Pleasure being here.
Welcome. Something about the epidemiology of dengue. Dengue is a pandemic-prone viral disease which incidence has increased 30-fold in the last 50 years. Nearly half of the world's population lives in dengue endemic areas, and the Asian countries are most affected. Approximately 70% of all cases comes from Asian countries. However, currently dengue fever is rapidly spreading, increasing in incidence in South America and in Africa. To date, dengue virus has been detected in more than 100 countries with 100 up to 400 million infection and up to 96 million symptomatic infection per year, resulting in 2.4 million disability-adjusted life years and more than 36,000 deaths in the past 3 years. Global data on dengue infection worldwide could be underestimated, however, because the epidemiology and burden of dengue in Africa is poorly characterized, but recent outbreaks indicate a potentially larger burden than it's currently estimated. This spectacular expansion of dengue has several reliable explanations. The rapid, uncontrolled urbanization in various geographic areas, particularly in Southeastern Asia, has drastically amplified both epidemic and endemic transmission cycles. Modern transport and enhanced globalization, including rapid travel and trade, have enabled the importation of dengue virus by overcoming natural barriers of travel time and geography, which had previously limited its expansion from endemic area into non-endemic area. The European region has been mostly spared by the global spread of dengue. In other words, to date, dengue mostly remains a pathogen associated with international travel, and it's a relatively common cause of fever in travelers returning from South and Southeast Asia and Latin America. Since dengue fever is such a widespread disease, the risk is very variable between regions and epidemiological condition. The travel-related risk is affected by duration of trip, repeated travel, type of travel, frequency of outdoor activities, type of accommodation, and also seasonality of mosquito density. The principal symptoms of dengue are high fever and at least two of the following signs and symptoms: severe headache, severe eye pain, joint pain, muscle and bone pain, rash, mild bleeding manifestation, low white cell count. Generally, younger children and those with the first dengue infection have milder illness than older children and adults. Dengue-infected patients are therefore either asymptomatic or they can have three clinical presentation. One is like a viral infection, is undifferentiated fever. The second one is a dengue fever with or without bleeding. And finally, the more severe manifestation, dengue hemorrhagic fever or dengue shock syndrome, characterized by plasma leak syndrome. Dengue fever virus constitutes four main distinct serotypes, from 1 to 4. Infection with one serotype results in long-term immunity against the specific serotype, but only short-lived immunity against the other serotypes. And patients who acquire a second dengue infection caused by a different serotype are at an elevated risk for severe dengue once cross-protection induced by the first infection wanes. And the potential mechanism for increased risk of severe dengue caused by second infection include cross-reactive antibodies binding to heterologous dengue viruses. This may enable uptake in antibodies receptor-bearing monocytes, macrophage, and dendritic cells that leads to higher and more prolonged viremia, inducing unbalanced pro- and anti-inflammatory response. This is called antibody-dependent enhancement. Also, the action of non-structured protein, NS1, on the vascular endothelium that triggers the release of vasoactive cytokines from immune cells can lead to hyperpermeability and vascular leak responsible for severe infection. Thomas, let's move on to the dengue vaccination. What can you tell us about the vaccines currently available?
Thanks, Nicola. Given the dramatic increase of dengue over the years, there has been intensive work on vaccines. But development hasn't been easy. It's been hindered by the fact that we're actually dealing with 4 infections, 4 different viruses with a severe cross-reactivity, and that had a lot of implications for the manufacturing or the creation of vaccines, actually. The first one that became available and was licensed in Europe about a decade ago was the CID-TDV vaccine, which is based on the yellow fever vaccine virus. It's actually a very clever concept. First results were very promising with basically 100% antibody reactions against all 4 dengue viruses. And then basically after licensure came the disappointment because the actual protective efficacy was much lower than expected. In people who had already dengue before, who were seropositive, protective rates were about 60%, which wasn't too bad. And then they found that in non-immune people who were in contact for the first time with dengue antigens through the vaccine, protective efficacy was around 20%, and that was quite low. And then a signal rose about 2 years after the start of the studies, of phase 3 studies, that those who were non-immune, who were naive and who were vaccinated, and then had contact with the wild virus developed a risk of an ADE, as you mentioned before. When you had already an antibody response and get in contact with a new virus, then the clinical course might be more dangerous and you might develop dengue hemorrhagic fever, and that's what happened. So even though it has been licensed in Europe, it was actually never used on the continent apart from French overseas territories where there's high pressure from dengue infections. If you look at the pooled protective data of the trials with this vaccine, the protective efficacy wasn't too bad for those who were seropositive. As said, the first results were around 60%, but in the end it was about 81.9% protection, and against severe dengue even 93.2%. So that's the reason why it has been used in regions where there is a high dengue infectious pressure, but only in those who already went through at least one episode of dengue. The other vaccine, which was licensed in 2022 in Europe, has been developed in a different way. And of course, there has been a learning process from the first vaccine. So here was the dengue 2 virus used. It was attenuated genetically on 3 modifications on the genome. Again, this vaccine has a very high, or induces a very high immune reaction. So antibody responses are strong. No surprise, that's what we know from the other vaccine too. The difference is that the basis is a dengue virus. So reaction is to the complete dengue virus and not only to parts of it, as in the first vaccine where you had a yellow fever virus with small parts of dengue virus included. And the crucial difference probably is the reaction to the non-structural protein 1, NS1. And with this vaccine, you develop antibodies against the envelope of dengue viruses plus against NS1. And that may be the crucial difference. The protective efficacy in the overall population in the phase 3 studies was 80.2% here. And that was basically the same after the first shot too. It was 81% here. And protective efficacy against complicated dengue with hospitalization was 90.4%. So that sounds pretty good, but they were not able to show significant protection against dengue type 4. And in dengue type 3, they had no protection in non-immune subjects. There was protection in those who already had dengue, but not in those who were non-immune. In addition, there are few data on older adults yet, and we don't know whether the reaction of old immune systems is the same as in young patients, children, and young adults where the studies were done. And on the plus side, after more than 5 years follow-up now, there's been no signal of an ADE reaction. The long-term efficacy and safety of this vaccine are still being followed up. There's an ongoing double-blind randomized placebo-controlled trial in those participants of the first studies, aged 4 to 16 years. And the cumulative efficacy here is 64.2% in dengue-exposed subjects and 53.5% in dengue-naive participants. So the efficacy drops over years, obviously a little bit. Efficacy was demonstrated against all dengue serotypes in those who already had dengue, but not in dengue-naive participants. Here we have demonstrated efficacy against dengue types 1 and 2. All in all, it's a vaccine that is working, but it has limitations, obviously.
Thank you, Thomas. I would like to add that personal protection measures against mosquito bites, such as topical repellents to exposed skin or using loose-sleeved shirts and pants, should be continued after vaccination. So we have learned about the benefits of dengue immunization, but how can we implement dengue vaccination in travelers to endemic region, Thomas?
Well, with dengue increasing worldwide and the risk for travelers being apparent in most destinations, actually overseas destinations, we actually started using the vaccine very fast in Germany, as this was the first country where the vaccine was available. We were actually the first clinic in Germany using the vaccine. Over the first years, we applied more than 26,000 doses to travelers. And using the broad indication according to the EMA authorization. A single-shot vaccination before travel was regularly applied because the vaccination schedule is a bit of a hindrance for travelers, really, if you want to apply both vaccines, because there's a first shot and then a second shot after 3 months or later, and most travelers don't come that early, so they have to leave with the first vaccine and receive the second one later. And that obviously in terms of protection doesn't make a difference, because the data we have, which are published, show the same protection after the first vaccine as after the second. The second appears to extend protection but not really increase it. We had a very good acceptance from the start from our travelers. Actually, most people came actively and seeked the vaccine, either because they had dengue or friends had dengue and they wanted to be protective. And that's still the situation. We see many people who come and actually ask for the vaccine because they see there's an increased risk and they want to be protected. What we introduced was an active surveillance studies for adverse events because we wanted to learn about this in our population, in adult travelers. And after 1 year, we saw local reactions in 47.9%, flu-like symptoms in 24%, fatigue in 40%, muscle pain in 28.5%, and the rash in about 17%, 16.7%. The rash came as a bit of a surprise because it's not been detected in the phase 3 studies. But obviously that was very different populations. And important is that all the systemic side effects tend to appear in the second week after vaccination, so with some delay. And that makes last-minute vaccination before the journey a bit problematic, because then the side effects may occur during the journey. So this 2-dose schedule we have basically turns out for our travelers to be a 1-dose schedule before departure, and then the second dose is a catch-up vaccination after they returned or even before the next journey. There are published data that show that vaccination after 1 year with the second dose is at least as effective, if not a bit more effective, than vaccination after 3 months. So one does not need to restart vaccination, of course, if the interval is extended. And of course, it should not be reduced, shortened, because with this live vaccination, there's no point in giving 2 shots in brief time after each other. Protection against disease starts about 14 days after the first shot, which again points to a problem with last-minute vaccination, because if you get vaccinated and then start your journey, you will not be protected during the first days or 2 weeks of your journey.
So, Thomas, which travelers should be offered the vaccination against dengue?
As I said, we have travelers who are coming and actively seeking the vaccine, so we actually have to turn away a few of them, and that's been the case from the first days when we had the vaccine available. Obviously, we offer the vaccine and give it to people who already had dengue fever. We know it is working well here, and so that's the group that has the strongest recommendation. But we also offer it to all travelers going to areas with current outbreaks of dengue, and to travelers to areas with high endemicity. And that goes for many destinations, actually overseas destinations. Travelers to low-risk areas came as well. And we've been, for example, asked whether you should have a dengue vaccination for travel to Italy, because there were a few cases last year in the region of Lake Garda, for example, which is popular with German travelers. But that's been 8 cases. And to vaccinate for these few selected cases, a whole traveling population to northern Italy would be a bit of an overkill in our eyes. So that's what we usually don't do. But then we do have residents, for example, in areas where they know that dengue reoccurred, like the south of France, the Côte d'Azur, which has seen out-of-towners dengue transmissions since 2013. And some of them actively seeked the vaccination because they said, why should I be at risk when I am there every summer? And this way it may be offered. We do not offer and do not give the vaccine to those who are pregnant and breastfeeding, those who are immunocompromised, it's a live vaccination, and to children younger than 4 years, because it's not licensed in those groups.
Thank you, Thomas. How can we effectively communicate the benefits of dengue vaccination to travelers, in your opinion?
Well, as a start, there's no need to teach most travelers about dengue. They're quite aware of it, and especially people who have been traveling before, because dengue is now very visible in many destinations. And it's also being picked up by the press, so people know that this is an issue. I think we should point out that our options in terms of vaccination are not perfect. We can offer a partial protection, which is certainly better than no protection at all. But it's not that we can say if you're vaccinated you won't get dengue, especially for those who are immunonaive, who didn't have dengue before. We can't promise that we offer protection against dengue types 3 and 4. And since the dengue serotypes are circulating and changing in countries, and there are outbreaks of dengue type 3, for example, we can't promise them protection against these serotypes with the vaccination, but still the vaccine does offer very good protection against dengue type 2 and good protection against dengue type 1, and is safe. And it's the best we came up with up to now, apart from mosquito bite protection that you mentioned before. So it is something we do offer with the limitations I mentioned, and is part of the protection we can give to travelers to overseas destination.
Thomas, thank you for this great discussion, and thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.